Hello, good morning, everyone. Welcome to this new episode of European Early Intervention Journal on Air. About this format because so we are doing this since already 2 years, and so it's a pleasure. To be today with Roberto Scarsini from Verona. So thanks, Roberto. And
Thank you
for
very much,
those
Salvatore.
Thanks. And for those also, we are just at the first early intervention journal on air. So let me explain you a little bit so how it works. So the aim of this session is to have a very fast journal club, so about one article published on early intervention. So directly with one of the authors, and that is the reason why we have Roberto here, and we will discuss a paper that we will show you shortly. And we will have two different parts. So in the first part, so we will discuss with Roberto about this paper and the specific part which we think are of interest for you, so to understand. And then, so we will ask you, so if you have a question, but in the meanwhile, so you may ask any question that you may have. And at the end of this session, so we will try to get all of them. So if there are many, and we will ask so Roberto. So I guess that there will be many questions from you. And so I will start immediately, about this paper. So I guess that so you have read the last month every intervention issue, and there was a very interesting paper about the role of coronary microvascular dysfunction in patients with a severe aortic stenosis who have been treated with TAVI. So, and that is to me a very interesting topic, because on one side, so we have TAVI, so that is a very topic of interest, and the other side, so we have microvascular dysfunction, so which is something more about INOCA patients and ANOCA or MINOCA, no? And that is the reason why I ask you, Roberto. So which is the idea, actually, your idea behind this paper? Because so you are actually translating one thing about MINOCA to patients to TAVI. So.
Yeah, thank you very much, Salvatore. Yes, you're right. It's quite, unusual to export the idea of microvascular assessment beyond the usual settings. But I think the microvascular dysfunction can provide very useful information in different settings, such as patients with valvular disease, and specifically in patients with aortic stenosis. As you know, coronary microvascular dysfunction has been repeatedly observed using both non-invasive or invasive technology. And to me, the reason why this is relevant is twofold. So from one side, you have coronary microvascular dysfunction assessment may provide relevant information on the reliability of coronary physiology in this setting. As you know, nearly 1 in 2 patients with severe aortic stenosis may have coronary lesions that might be needed to be interrogated with the fractional flow reserve or non-hyperemic indexes. So to have a clear idea of which is the status of microvasculature might provide insightful information on if the fractional flow reserve, for instance, can be used and can be trusted in this patients. And the second reason why this is relevant to me is because in previous study we demonstrated that we can observe quite often and actually an impairment of coronary flow reserve in these patients, and in some of them the microvascular resistances are significantly increased, but not all of the patients with severe aortic stenosis presents, for instance, high IMR. So high IMR is observed only in some of the patients. So to understand which patients may have severe impairment of microvascular function can be very important to me to define its implication on the prognosis of these patients.
That is very important because so you know that people are every day so more interested to microcirculation, so to understand so how can get in the clinical practice and what are the data that they can get and how to translate this data in improving the prognosis of our patient. So actually, so could you tell us a little bit more about your paper? So, what was your methodology, your main findings, etc.?
Yeah, absolutely. So basically, this was a prospective study, observational study. It was a multi-center study performed in 3 European centers, so 2 Italian centers and the center of Aalst in Belgium. So we invasively assessed the microvascular function before and immediately after TAVI in a cohort of 134 patients. So microvascular dysfunction was assessed based on thermodilution methods. So both using bolus thermodilution and continuous thermodilution in one of the 3 cohorts. And the main tool that we used to define microvascular dysfunction for this patient was the novel index, the microvascular resistance reserve, which is a novel index which is more specific to microvascular function compared to, for instance, the coronary flow reserve, which, as you know, is a comprehensive index, but is severely influenced by the epicardial disease. So what we observed first was that the microvascular dysfunction was significantly associated with the extent of extravalvular cardiac damage in these patients. So the more severe the CMD and the more these patients present cardiac damage, apart from left ventricular involvement, but also right ventricular dysfunction or increased pulmonary pressures. And this is the first very important point. But then we observed also that microvascular function was associated with a low flow, low gradient phenotype. So patients with CMD tended to present impaired stroke volume index and low flow state. And also that patients with microvascular dysfunction tended to have impaired left atrium dysfunction. As I said before, we also measured these indexes before and after TAVI, immediately after TAVI in the vast majority of the patients. And we observed that the microvascular resistance reserve tended to increase and improve after TAVI in most of the patients. Conversely, the fractional flow reserve, so the FFR, tended to decrease, and this is something that has been already described. Conversely, the coronary flow reserve, which is basically a combination of microvascular and the epicardial index, did not change significantly after TAVI.
Yeah, well, that actually what you said was something impressive to me, no? Because so actually you put a TAVI and then so you got an improvement in microvascular function. So, and how do you explain, I mean, this improvement? So what was the TAVI doing, I mean, in this patient?
Well, this is a very good question. What I think is that the left ventricle unloading induced by TAVI reduces also the extravascular compression on the microvasculature, and this might be responsible for at least some of the exhaustion of the microvascular resistance reserve. Indeed, the vasodilatory capacity increased after TAVI, and this is also testified by the variation of the fractional flow reserve. So if you have a borderline value of fractional flow reserve, this immediately after TAVI, this value might change in terms of reduce. It might be reduce a little. After TAVI, because the vasodilatory capacity increases after the valve replacement. However, in the paper, we observed that nearly 30% of the patients presented a severely reduced microvascular resistance reserve after TAVI, so 28 point something percent. And this subgroup present a subgroup of patients in which probably there is also a component of vascular remodeling. So it is possible that an overt CMD prolonged for quite some time has induced vascular remodeling. And it is possible that these patients may not be able to have a complete recovery of the microvascular function after TAVI. However, it should be acknowledged that we have also data of the microvascular function immediately after TAVI, and we do not have the data at long term, so we don't know if the microvascular recover after a few months or years after TAVI.
Yeah, that will be, I guess, next step, no, of your research. So to call back the patients after 1 year, so and to again the microcirculation evaluation and to understand so how is going. I mean, this function. And then so I was curious. So, I mean, when you explained the methodology that you use, you know that I mean we are very young in terms of assessing the microcirculation, and many of us also don't know how to do it. But I guess that many of us are familiar with the bolus dilution. So the one that you use the pressure, the temperature sensor, and then so you inject bolus, and with boluses, so you get these nice numbers of IMR, CFR, etc. Actually, you say that you use a new method, so which is based on the continuous thermodilution, no? And that is something that I guess not many of us are familiar. So, I mean, I guess that you may explain us what is about and a little bit more in details. So it is more complicated, it is easier, how to make it.
Yes, so I think it's important to say, first of all, that the microvascular resistance reserve can be measured both using the bolus thermodilution and the continuous thermodilution, or even other techniques for the measurement of microcirculatory function. It is true, however, that probably the continuous thermodilution method is a more robust method and presents less inter-observer variability, and this was recently demonstrated by the group from Aalst. When you use the continuous thermodilution to measure absolute flow and resistance, basically you do not have to induce hyperemia using adenosine or other drugs, but you have a continuous infusion of saline at a different velocity at rest and in order to induce hyperemia. And this can be done using the pressure wire and a dedicated microcatheter. In this study, we, as I said before, the microvascular function was assessed with bolus thermodilution in 2 out of the 3 groups of patients and continuous thermodilution in 1. And we did not observe any significant difference in these cohorts. However, it is true that in other settings, in other studies, the continuous thermodilution has been associated with less inter-observer variability. So, and it is probably more accurate in order to make a diagnosis of CMD, because probably bolus thermodilution might overestimate some of the values. And obviously, for instance, the IMR, it is dependent on the operator, because as you know, when you inject the saline bolus, this can be done at different with different practice and technology.
Yeah, absolutely. So also, I mean, it is interesting to see that in the bolus thermodilution group, you didn't have any concern in terms of complication, no? Because you know that the patient with aortic stenosis sometimes, so you are avoiding, I mean, to give a nitrate to this patient, and you may be worried, I mean, to administrate adenosine. So, and I'm pleased, I mean, to see that it looks like a safe procedure, but of course, as you explained, so that continuous thermodilution doesn't need, I mean, adenosine, so there will be something even more accurate, you know, than that. And
Yeah.
so, I mean, my last question. So, I mean, I have many questions, but of course, so we don't have, I mean, much time. And I will also to ask all our viewers if they have any. So, will be actually, how do you think so all these findings may be translated to our patients, no? Because in the end, so we're making research not for making research, so it's not a sophistic action, no? But it's something that we want to translate, so to improve the prognosis of our patient. So how do you think so you may apply so what you have studied, what we have evaluated in improving patients with the TAVI?
So yeah, thank you, Salvatore. This is very, very important question. So I think the microvascular dysfunction in general, and specifically the microvascular resistance reserve emerge as a marker of severity of disease in these patients. So in patients with severe aortic stenosis and already a clear indication for TAVI. And we know that extravalvular cardiac damage has been extensively associated with prognosis in this patient. So it is reasonable to translate this association to the microvascular function. Indeed, in a separate study, we recently published in Heart that analyzing the retrospective data from the Verona valvular registry, we did this analysis based on the angiography-derived physiology, and we observed that microvascular dysfunction was actually associated with the prognosis after TAVI. So we assessed the long-term follow-up of these patients, and patients with high IMR, basically high angiography-derived IMR, presented a higher risk of cardiovascular mortality and readmission for heart failure at 2 years after TAVI. So I think this is important in order to refine even better the prognostic assessment of these patients when it's time to decide the timing for valve implantation.
Oh, that's very interesting. I mean, the next step should be also to understand that these patients, I mean, this specific subgroup that you said, so is a higher risk of events. So I guess that alongside the TAVI, so we need something more. So maybe, so if in the future, so we will have a specific track for microcirculation, so we may think that this patient may be a perfect target, no, in order to improve the microvascular dysfunction and the mortality, that they have so far high. So
Absolutely.
I don't see, I mean, any question coming from the audience. So I just say VJ Canadian, no, we all know she's an expert. I mean, in microcirculation, say that it's very important topic, and we agree actually with her, because that is the reason why we selected, I mean, your paper. And so if there are no question from the audience, so I will say, so thanks, Roberto, I mean, for being with us. So it has been an absolute pleasure, I mean, to discuss with you this paper. And I will also thank the community of Twitter, of every intervention, of interventional cardiologists who watch, I mean, this video. And also, I mean, every intervention staff. So we made possible to have this live session this afternoon. And I hope that you enjoyed this session as I did, and we hope to have you again with us, so in the future. So thanks, Roberto. Thanks, everyone.
Thank you, Salvatore.